all I was going to say is Amy comes to us by way of Jill Lewis. Again, one of the folks who helped plan this out is being highly recommended. And I talked to Amy on the phone and thought she was very knowledgeable and practical in just what in our quick conversation we had together. So I look forward to hearing her comments. Amy Ferarro is a manager at PCG. She has nearly 17 years of experience in public sector consulting. She has worked on a variety of revenue management, revenue maximization, consulting engagements, including Title IV-E, Medicaid administrative claiming, cost allocation, time tracking, including random moment time studies, and training. And look forward to hearing what she has to say and seeing if she can get down her wealth of experience into an hour. That's going to be the challenge. But she will be around for a while, I think, to answer questions well. So with that, I welcome Amy.
And we also want to welcome Dolores Cooper on the line. Dolores, can you just give us a quick introduction of yourself?
Hi, I'm Dolores Cooper. I'm with the State of New Hampshire Division of Public Health Services.
Thank you.
Great. Well, good morning, everyone. I have the challenge of being between you and lunch. So, as it's already been pointed out a number of times, I probably have the most boring topic of the day. So, thanks, Jim. Yeah. So I'm going to do what I can to liven it up. I'm also joined today by Matt Sorrentino, who is my colleague, and he may jump in a little bit as well. We're going to talk about cost allocation and revenue recovery. And one of the things that I hope to leave you with is the idea that a cost allocation plan, and I'm going to describe what that is a good thing to help set up revenue recovery across your organization. And so we're going to talk a little bit about that, about financial management and so forth. So I'm also going to leave some time for questions. And I will be sadly, I have to sneak out for a little bit this afternoon, but I'll be at the round table, and I plan to be here all tomorrow morning. So if I don't get to your questions, I'm happy to talk about it at some point. So with that, I will start. All right. So I'm going to kind of go through what a cost allocation plan is to start, talk a little bit about budgeting, indirect cost rates, kind of some tactical stuff, and then spend a fair amount of time on revenue recovery, particularly Medicaid. One thing that I've learned about working with public health is if you've seen one public health agency, you've seen one public health agency. And so one of the challenges, I think, is that there's different opportunities depending on where your organization sits, what kind of programs you have, and so forth. One of the things that I spoke about with Jill, and I'm happy to sort of talk about it here today, but also talk about it in general, is it sometimes seems as if a public health entity doesn't fit with a Medicaid agency, there's kind of a translation issue. And how do you work together to try to explain what one agency's responsibilities are versus the other to try to come together to try to realize additional funds? So that's hopefully something I don't know if I have a lot of words of wisdom, but can certainly give some examples of where it's worthwhile. Before I start, I have a question, kind of a show of hands question just to get the lay of the land. First of all, how many of you have a cost allocation plan? Okay. How many of you don't know? Anyone? Okay. How many of you also have an indirect cost rate? Both? Okay. And how many of those processes are integrated? It's the same process to get both results. Okay. One of the things I'm going to talk a lot about is sort of the integration of financial tools. We're kind of believers that every quarter, every year, I should be pulling my cost allocation and my indirect cost rate allocations process together in a single process. Because otherwise, how do you know you're not double counting, right? So if someone's over here and they're responsible for the cost allocation plan and someone's over here responsible for the indirect cost rate and they're doing those things in vacuums or silos, how do you know they're not pulling the same costs and including them in both? And that's something that, unfortunately, we see a lot. So that's helpful for me to get a little bit of the lay of the land. Okay. There we go. Okay. So just a little bit of boring, really boring stuff, the federal regulations. A cost allocation is kind of a generic term as well as a specific term. specifically, it's the whole process whereby you take all of your costs. Okay, so all of you can probably pull financial data from your accounting system, right? You know how much you pay people. You know how much you pay for the building, rent, heat, lights, hot water, conference, travel, buying supplies for clinics, whatever it may be. Folks know how much they spent on stuff. The whole idea of cost allocation is to figure out, all right, I spent a bunch of money. What did I spend it on? And more specifically, what programs did it benefit? So one of the whole ideas about cost allocation is you have to get into this idea of benefiting objectives. So I have to take my salaries and I have to figure out, all right, how much of that can I allocate to WIC? How much can I allocate to SNAP? How much is some state-funded program? How much is a grant, whatever that source may be? And that's what the whole idea of cost allocation is. So there's cost circulars out there and cost principles that we all have to follow. So I'm hoping all of you have heard about OMB 87. I won't ask for a show of hands there. If you haven't heard about it, you should probably go read it. Definitely a cure for insomnia. But essentially what OMB 87 does is it kind of sets forth the cost principles, and along with some other regulations, it kind of sets forth, okay, how do I go about figuring out, I spent all this money, what did I spend it on, and how can I use it to draw down funds? And obviously it goes into lots of detail about what's a direct cost and what's an indirect cost. Lots of cost allocation is in the gray area. It's easy if I pay a nurse and all she does is prior authorization, pretty easy to figure out how to charge her time. If I've got someone else and he's working on multiple grants, it gets a little bit trickier. I'm not going to get into a discussion of what's a direct cost versus an indirect cost. I don't really care, to be honest with you. I think the whole idea of cost allocation is looking at every single cost you incur, no matter what you want to call it, it's how do you eventually get it to the benefiting program and where it supports something. There's basically two ways that you can go about doing cost recovery. Now, cost allocation, this is one of the things I kind of want to talk about. If you're going to claim, quote-unquote, administrative costs, typically you're going to have to go through a cost allocation route to get there. What we like to do is we actually like to set up cost allocation plans that both identify all of your administrative costs and all of your direct costs. One of the hopeful lessons from this presentation that I like to leave is that you can use a cost allocation plan to set up your direct costs so that if you have to go put together cost-based rates, you have it all ready to go. You can use your cost allocation plan to set up your costs if you operate facilities. You have your costs there. As a public health entity, you actually don't have to do a cost allocation plan most likely, depending on where you sit. So there are certain agencies out there, Medicaid is one of them. They have no choice but to do a cost allocation plan. It's in the federal regulation. You can only claim a cost to Medicaid as administration, and all Medicaid dollars are a service dollar or an administrative dollar. Every single cost has to get boiled down as one or the other. You can only claim Medicaid administrative dollars if it's part of an approved cost allocation plan that's been approved by the federal government and is set up. Otherwise, you're not supposed to be claiming it. So public health agencies, if they're standalone in particular, fall outside of that. You're not a single state agency. So actually, by letter of the federal law, you don't have to have a cost allocation plan. So what lots of public health agencies do is they have an indirect cost rate instead. And so an indirect cost rate you do have to have, and that's how you're going to assign a lot of your indirect costs to your direct programs. So that's one of the reasons why public health is sometimes a little bit different. You don't necessarily have to go through all the effort of doing a cost allocation plan. One of the things I want to talk about is how there's a lot of benefits to at least trying to do one or setting one up. The public health agencies that I've worked with is kind of a mixed bag. Some have full cost allocation plans, couldn't imagine doing anything differently. Others rely on indirect cost rates to basically assign. And again, I think the size of your organization is going to drive a lot of that. If you're relatively small, you may not need a full cost allocation plan. That's a little bit of a stretch for me. The bigger you are, the more moving parts you have, particularly if you're going to start to claim some of the big federal programs, such as SNAP or Medicaid and so forth. You are going to probably need to have a full cost allocation plan, even if it's not required. All right. This graphic really just kind of shows, for anyone that's not, I guess my definition of a cost allocation plan is it's really two parts. And a cost allocation plan is going to be based on your organizational structure. So essentially, again, it describes everything that you do, all the people you employ, what everyone does, all the programs you operate, and then it goes through and talks about how you're going to figure out of all those costs, what benefits what programs, be it federal, state, private, and so forth. So that's really the kind of goal of it. They have to follow your organizational structure, and a cost allocation plan is going to be comprised of two parts. There's the narrative document, the probably Microsoft Word document that's in English that says, John does this, and we're going to allocate John's cost this way. And then there's the financial backup that's actually the process. Those two pieces have to match. So you can't have a narrative document, which is often what the federal government looks at or your cognizant agency looks at, that doesn't match what you're actually doing in reality and what you're actually calculating, and vice versa. And again, a Medicaid agency has to do this. A child welfare agency has to do this, particularly with the ACA and some other things going on. A public health agency may or may not do it, but one of the other reasons we stress that cost allocation plans following all these rules is good for a public health agency is because it kind of forces you into a discipline that you may not otherwise have. If you have a written document somewhere that says how we're going to treat costs and says how we're going to allocate costs, you're more likely to hopefully follow it and be consistent in your revenue recovery efforts as opposed to not having something and not following it. Bottom line is, whatever process you follow, whether it's an indirect cost rate, whether it's a cost allocation plan, whether it's a combination of both, you have to follow this better seen objective approach, and that's the link there. One thing that's kind of interesting when you get into the world of public health, even if you have a choice of what methodology to follow, some of your funders may not be as educated about one option or another. So if you go start talking to Medicaid about indirect cost rates, they're going to probably not, engage in the conversation much longer because you have to be able to identify costs not using a rate. CDC, kind of in particular, my experience is that when you start talking about a cost allocation plan, they're like, where's the rate? They want to see it expressed as a rate. And so if you can't say it's 10% and 12% of my indirect costs are charged to my direct costs, sometimes you get some quizzical looks on that side. So a cost allocation plan can be, the results of which can absolutely be expressed as a rate. So that shouldn't be something that kind of stops you from moving to a full cost allocation model if you're using a rate right now, because you can always, show it that way. And I think a lot of times, too, your grant awards and applications that you're applying for want that rate. We're actually seeing, in some cases, those applications change. So that you have the option of sort of expressing a full number from a cost allocation plan or being more specific instead of just trying to push that rate in there. One of the reasons why cost allocation and full cost allocation is better often than a rate is a rate's a one-size-fits-all approach. So typically what happens is you develop an indirect cost rate for your agency, you're saying that it costs us, our indirect costs are going to get charged to all these grants equally. Because that's essentially what you're saying. Our rate is 10%. Well, it may not be that way. You may, what if you put computing costs in your indirect cost rate and you have a group of staff out there, particularly in public health, that aren't using computers? Or what if you have, a high level of policy or programming staff and they're not benefiting all of your activities equally? You really want to try to think about whether a rate, one-size-fits-all approach is benefiting you or not. And what we tend to find is, in some cases, it overcharges, and in some cases, it undercharges. So, getting more specific and getting into a cost allocation plan usually gives you a bit more discretion and a bit more, wiggle room is probably not the right word, but, just a bit more flexibility in how you're going to figure out your cost recovery. Another thing, too, is localities. If localities, and that could be, organization that you're claiming, any kind of city, town, county, if you're a state-based system, however it works, is going to be claiming funds, particularly if you're going to try to claim the Medicaid funds that a locality incurs to the Medicaid program through public health, through Medicaid. They kind of have to follow the same set of rules. So it's important to note that the funder tends to drive what set of rules have to be followed. So increasingly what we're seeing is that localities are having to prepare cost allocation plans and indirect cost rates and so forth if they weren't asked to before. Same goes for like school-based billing. School-based billing is essentially the way that whole process works is kind of a microcosm of a cost allocation plan. Another thing to just sort of mention, I won't dwell on this, but we get a lot of questions about cost allocation versus budgeting. And one of the things that I see a lot of organizations do is let their budgeting process drive their cost allocation process. And I'll joke, when I go into an agency, I could care less how you budget your costs. Don't care. Doesn't matter. It's what did you do? What did you actually spend the money on, and what programs ultimately should they support? So a lot of times what you see happens is I'm not allowed to hire someone unless I can say that a certain amount of their funds are going to be federal. So basically it looks like I'm trying to limit the state cost of hiring someone or adding a new function in my organization. So someone will come across on paper and say, well, I'm going to take this grant and I'm going to use it to fund this position, so therefore there's no net increase to the state. Well, what happens if they're actually not working on that grant? Or what happens if they're actually working on something that could be charged somewhere else that would be more beneficial to the state? So what you want to do when you do your budget is, ideally in the long run, you want to have a process where your cost allocation and your budgeting processes are kind of married. But when you do cost allocation, what you're looking at is, unless I know that someone spent 100% of their time on WIC or 100% of their time on a bioterrorism grant, or, and I can document and prove that, I want to treat them as a clean cost, a general funding cost, go through my cost allocation process, and let the kind of cards fall where they fall based on what they actually did. And so a lot of times what we see is we see budgets get set up, and those budgets are actually hard-coded into an accounting system, and that drives where costs are claimed, but it doesn't match reality, so it kind of sets up an audit problem potentially, or what it does is it actually decreases the amount of revenue a state can bring in, particularly when that person could be claimed in Medicaid. So I've seen people that are working on 100% Medicaid allowable activities funded with TANF dollars, or funded with SSDG dollars, or funded with a grant dollar, because that was the only way that position could get funded, or just because that's, I don't know, how it was done. And then the state isn't drawing down that federal revenue from the other source. So it's just something to keep in mind that budgets and cost allocation are two very different processes. And I'm happy to answer some questions about that towards the end. So one of the things with your cost allocation in particular and your capped grants is, you got to make sure you have everything straight, everything clean, everything audit proof, but you want to have a cost allocation plan that has flexibility around where you're charging, particularly some of your capped grant sources, which a lot of you have a lot of those. Okay. So that gets us a little bit into hopefully what a cost allocation plan is, and gets us a little bit into sort of grant cost recovery. And then I'm going to talk a little bit more about Medicaid cost recovery in particular. The reason, with Medicaid is that's a big funding source, and you all are working with folks. In most cases, a decent number of your clients are Medicaid eligible, and that's going to probably be increasing in a lot of your states over the next 12 months and forward. But one of the things that a cost allocation plan can help you do is, like I said, kind of take away that one-size-fits-all approach when you're dealing with an indirect cost rate. In the first example we have here, when you're sort of dealing with your indirect costs and you're trying to figure out how to allocate your indirect costs, if you look at something like a human resources cost, chances are it's pretty hard to argue that human resources doesn't touch every person. okay? So you're probably going to, if you were doing an indirect cost rate, if you were doing a cost allocation plan, you're going to kind of allocate your human resources costs equally. Pretty easy example. But when you get into other types of quote-unquote indirect costs and other types of support costs, it may not be that cut and dry. We see lots of functions, particularly, public health agencies that operate facilities in particular. If you're using an indirect cost rate to drive down costs to your facilities, or you're using like an FTE count across the board to drive down indirect costs to your facilities, maybe to go into completing your facility cost reports for Medicaid and Medicare, a lot of times you have a large number of staff at a facility that don't use a computer. You have janitorial staff, you have security staff, you have a lot of even health staff that don't need that kind of access on a regular basis. So you really want to try to be targeted in your approach. And so our position is that a cost allocation plan is a targeted way of making sure that you're only charging to grants the specific costs that they incur, as opposed to kind of a one-size-fits-all approach. The other thing that, a cost allocation plan can do, and we heard a little bit about this last night, it can give you a lot of data and information about whether, I always joke, is it costing you $1 million to operate a $10,000 grant? So sometimes, folks will go after these grant opportunities, but if you're just applying indirect cost rate to those costs and you're not really kind of paying attention to what's the true cost of the program, that could be information as to why are we going after that grant. I mean, if it's a program that's really important and you're looking at the grant that you're bringing in as an opportunity to help defray the cost, it may be worth it to you no matter what the size of that grant is. But in some cases, if you're not doing good cost accounting and you don't truly have your eye on the actual number and you're not really sure how much it really is costing you to do this, it can help you give you some management information and so forth. So just sort of something to think about. In terms of Medicaid cost recovery, most, and again, have to preface not all public health agencies look alike. So some states are really using their public health agencies as a true safety net provider, and you don't have a high Medicaid penetration. But a lot of public health agencies are serving a large population that is Medicaid eligible. So what certain public health agencies have done very well is to partner with the Medicaid agency to get Medicaid reimbursement for the services that they are already providing. So it's very common that, too, that we'll see a public health agency that may be doing really well on the direct billing side. So there's a lot of direct billing and they're getting reimbursement that way, but they're underestimating Medicaid administrative costs. So they're underestimating the cost that they may actually be spending to enroll people in Medicaid. Oftentimes people will come through the door in a public health clinic without coverage, and if you have 2, 3, 4, 5, maybe more people that are actually devoted to doing Medicaid eligibility determination so that they can actually get coverage, that's an allowable cost that you can draw down federal funds on. And so a lot of times we'll see, even if one side of the shop is really in good shape, some of those Medicaid administrative functions may be ignored. The graphic here just gives a flavor, and it's only a flavor, of some of the places that Medicaid activity may be performed and may be recoverable. And I think that's another thing that oftentimes it gets overlooked. When Medicaid agencies were first created, when the Medicaid program was created in the 60s, a lot of the service delivery actually occurred out of that entity. So that's where the service delivery was happening too. Now, very few Medicaid agencies are the ones actually providing the service and performing the activity. It's through a wide range of networks, ranging from HMOs to school districts to clinics to schools. And so there's opportunities to sort of go out, catalog, and say, all right, who's doing what where? How are we funding those activities? And is there an opportunity to draw down, additional federal dollars for things, in a lot of cases, that you may already be doing? Medicaid reimburses, as I mentioned, for both direct services and for activities, or what's called Medicaid administration. And again, you could have people who are doing both. You can also have people who are only doing administrative activities or only doing direct service. So, direct service claiming can take many forms, be it, actual providers or actually in facilities. The Medicaid administrative claiming, sometimes called MAC, can take many forms. You have many people out there. I would not be surprised if some of you are actually costs in the Medicaid program. Depending on the partnerships or where you sit within an agency, are your costs being claimed in part from the Medicaid program? Could they be? The Medicaid program allows for reimbursement of activities that are for the proper and efficient administration of the Medicaid state plan. You can kind of drive a truck through it at the first glance. But there are often times, where there's partnerships with various agencies and folks like yourself, other folks, program policy, rate setting, other staff within an organization are performing allowable costs. So it's something, to look at. It might be worth just sort of performing an assessment of all your functions, who is out there, who's doing what, and what are we claiming in Medicaid, and are there ways that we could, in fact, increase it. The Medicaid admin in public health is an opportunity, particularly in clinics and other types of community-based programs, where you have folks coming in to receive services, direct services. You may be billing those services, but are you getting reimbursement for the eligibility activity? Are you doing care coordination? If it's an STD clinic, folks are kind of coming in and out, there may not be a care coordination. If it's a primary care clinic, and that's where folks are receiving their health care, there could be very well a care and coordination monitoring. Are you making sure that folks are getting services that they need? Do you keep a written case plan for all those clients? If you do and you're not receiving Medicaid reimbursement for some of those folks, that might be something that you could look at. And then we also mentioned Medicaid grants here, particularly under the ACA. There's all kinds of grants funded. I'm calling them grants, but there's a lot of different opportunities, particularly looking at, behavioral health, primary care, public health, Medicaid integration that are the opportunities out there. Someone this morning, I haven't read it yet, just forwarded me a grant opportunity that marries public health and child welfare. So there's lots of different opportunities out there and new grants. And I have to read it, but I will forward it to you. That are out there that if you're, appropriately identifying all of your costs, you can maximize some of your funding. One thing just to sort of talk about, and I know I'm talking about Medicaid at a very high level, but recovering Medicaid dollars is not easy. And I think that is sometimes why some of these programs fail. Particular state in the South actually recently stopped its Medicaid administrative claiming project simply because they felt that it was a lot of trouble, and they were bringing down about $5 million a year, and I don't think really understood or realized the level of effort it takes to get Medicaid dollars. I think if you go into it kind of though with the right financial controls and the idea that it's going to take work and it's going to be ongoing, I think it's a little bit more palatable. And, I'm kind of one of those folks that if you know what to expect and you know what the requirements are, it's a bit easier to sell, it's a bit easier to know, and it's less likely to kind of get taken away or come off the table. Because in my opinion, with this one particular agency, $5 million is $5 million. And, in the time that we live in with the tight resources, particularly in the public health world, that's real money. So some of the things to kind of just keep in mind about Medicaid is that you're probably going to have to time study staff. Now, I could talk for 3 days about time studies. I won't do it. This is art and not a science. But oftentimes what happens is you do have folks that are doing both direct service and non-Medicaid activities and administrative activities and so forth. So you have to time study them. There are good ways to time study people and bad ways. And unfortunately, the word time study is kind of a misnomer because it implies it's time limited. With any kind of Medicaid recovery effort, if it's a question question of staff person performing multiple activities and supporting multiple programs. If you're going to draw down Medicaid dollars or SNAP dollars or TANF or some of these other funds, you do at the time study them ongoing. It's ongoing forever. Kind of the hallmark of the Medicaid program, different than a lot of the grants, is current quarter costs, current quarter statistics, current quarter billing, and so forth. So those processes are operational processes. They don't go away. Another thing we find a lot is that the public health lingo just doesn't match with how Medicaid folks speak. And I think that some of the difficulties that public health and Medicaid agencies have in working together is that the Medicaid agency is very prescribed in how they describe things. And that's because the Medicaid agency has this burden of having to explain to CMS, Centers for Medicare and Medicaid Services, why they should pay for something. And that language isn't always user-friendly. It's not, in child welfare, it's particularly unfriendly. It can be equally unfriendly in public health. And it really requires a dialogue between the various entities to understand what the requirement is and understand why you have to describe something a certain way. I spend a lot of time working with social workers, an inordinate amount of time working with social workers, and it can be very challenging to say to a social worker who's working on a strengths-based practice model why they have to describe their time and why they have to describe their activities using these words that the Medicaid agency says they have to use. So you kind of have to create a crosswalk between the two languages, and I find that often happens in the public health world. Public health agencies have to negotiate via the Medicaid agency. So one of the things I think is if you're not sitting with a public health agency, you don't have the opportunity to go talk to CMS by yourself. It's actually prohibited by law. So, you have to create partnerships, and that's hard in some cases, particularly how agencies work with each other. In each state, you have a single state dedicated or agency that's designated as the Medicaid agency, and they're the only ones that can negotiate with CMS. So if you're outside of that, you have to have that partnership and that working relationship together so that you can access those funds. They're the ones on the hook if there's a disallowance. If they're doing their job, they're going to sign an interagency agreement with you that makes sure that you're on the hook if there's a disallowance. And oftentimes that's where some of these efforts might fall apart. But it's important to just understand the Medicaid role and what they're required to do so that you can try to get through some of those issues and create partnerships. Cost allocation methodologies and plans require, proper care and feeding. Lots of times, someone writes a cost allocation plan, and just like the strategic plan, if you put it on the shelf or you put it in the drawer, it's useless. It's a living, breathing document. It has to be followed. The math has to be run all the time. So it's important to just know that these things require some effort. And obviously, the more funds you access, the less state funded you are, particularly if you start to access Medicaid funds. You've got to be audit ready at all times. So, that's an added burden, so to speak. Hopefully it's offset by the additional funds into your organization, but it is something to keep in mind. Medicaid dollars can be used to defray some of the costs of things that you're already doing. And then there is going to be potentially greater opportunity for states under the ACA. Now, it was interesting last night because, it's interesting to hear the fact that increased Medicaid enrollment and increased HMO or enrollment through exchanges may decrease some of your state allocations. So that was, interesting to hear. Obviously, you're aware of it, and it was interesting to hear what a concern that is. But it is true that once the ACA goes through, in most of your states, you will be looking at increased Medicaid population, and you will be looking at an increased number of folks who have some form of insurance. Now, what that insurance pays for, what services they need, how they access services, that's all kind of what we're all nervous about and what's up in the air in some places and a little bit more settled in others. But theoretically, you are going to be looking at a higher percentage of individuals with insurance. And so in some cases, that may allow you to get at some of the really hard to serve. I did some interviews with the folks in Nevada, they actually have set up a specific program to help go after folks who are uninsured. It's a cash-based program where they get doctors and nurses to volunteer their time and actually accept cash for services that the folks have to provide ahead of time. A lot of their clientele now is going to be eligible for some form of insurance, whatever it may be. So they're saying, all right, now we can kind of rededicate our time to the undocumented aliens and others who are in our state that need access. So that's kind of what they're gearing up for. So it's going to impact all states differently. It's not without complication, but it is just something to keep in mind. I would think that a state with a lot of clinics, if you're not actually accessing Medicaid funds, particularly the Medicaid administration, now might be a good time to try to implement some of these programs and processes because you can get some revenue now. Theoretically, that revenue would increase if your Medicaid eligibility rate increases as well over the next couple of years. Okay. These are just a few steps in terms of just how to partner with the Medicaid agency. One of the big, things that you have to do is create that partnership, sign interagency agreements. I know in Louisiana they're called cooperative endeavors, whatever you might call, that piece of paper, that agreement you have with another entity about who's responsible, who's going to do what, who's responsible in the event of an audit, where the state match is going to come and so forth. So all that has to be set up for any kind of Medicaid claiming initiative, including Medicaid administrative. You have to get approval from the Centers for Medicare and Medicaid Services. It's a lot more involved than probably anyone wants it to be. So that's something that's important to keep in mind. A lot of times when you're applying for grants, it's kind of like a time-limited, there's season to it, you hear back. It's kind of an ongoing process. Medicaid could take as long as it takes. So sometimes it can take 2 years, sometimes it takes 3 months. So oftentimes you just have to be prepared that negotiating some of these things, particularly if they're a little bit outside of the box, can take time. And one of the things we didn't even mention here is the idea of Medicaid waivers to fund some of your populations and activities. So, Medicaid waivers also are a pretty involved process. And then any kind of claiming you're going to be doing where you're going to be using your costs as match, you're just going to have a process to be able to quantify your costs on a quarterly basis with the Medicaid program or a regular basis if it's setting some sort of rate. And that's, one of the things the cost allocation plan does for you is help you figure out what the true cost is. So particularly when you're, looking at some of these entitlement programs as opposed to a capped grant, you want to make sure that you appropriately account for all of the costs that you're incurring. When there's a bullet here in a few minutes about with your capped grants and a cost allocation plan, you have to allocate your indirect costs to that grant whether or not it can pay for it, right? So the biggest mistake you can make is saying, well, these 5 grants won't pay for the indirect cost, so I'm not going to allocate it there, and I'm going to allocate it somewhere else, which means you're overcharging your other programs. You absolutely cannot do that with Medicaid. Medicaid will not sit kindly if it finds out it's helping to defray the cost of all your grants that won't accept indirect costs. But at the same time with the Medicaid program and the CHIP program as well, the Children's Health Insurance Program, you want to make sure that you're at least quantifying all your costs and, getting it as high as you possibly can without going over. It's kind of like this Price is Right rule. So you want to make sure that you account for everything. As we say, you're entitled to every dollar. You're entitled to no more, no less. So it's really important that you do that with Medicaid recovery. Okay. So just a couple more slides, and then I'll open it up for questions. Some of the kind of common pitfalls we see as far as cost allocation, indirect rates, revenue recovery, is agencies not being able to fully identify the amount of cost to operate a specific program. If you don't know how much it costs you to operate every single one of your programs, grants, etc., you could either withstand a review of your cost allocation plan, or you could probably use a cost allocation process. A good cost allocation plan is going to show you how much it costs to operate all of your programs, activities, grants, and so forth. Agencies obviously not allocating according to the benefiting objectives approach is an issue. because you're probably over or undercharging somewhere. And those are the things that, you know, single state auditors love to find, other auditors love to find, and it's important that that's followed. Another concern we see a lot is that agencies will pull cost data for different purposes without a central process to ensure that costs are not duplicated. So someone over here is setting a fee-for-service rate, and they're including the entire cost of the HR department in that particular rate. Versus someone else is pulling costs from another source to do another rate or cost report or figure out a grant or so forth, and there's no communication or talking to for those separate processes. What a cost allocation plan does is it's one central process. The output is like, okay, here's the cost to provide that service. We're going to take that cost and go develop our rate. And you know that there's no duplication in that effort because it's gone through that process. As I mentioned, agencies sometimes rely on indirect cost rates to allocate their indirect costs, kind of creating winners and losers. Another couple I didn't mention, keep in mind that with a cost allocation plan, you can't allocate costs based on estimates. And this kind of goes for your grant applications as well. It's, you know, I've seen it where someone will take Joe's salary and they're saying, okay, Joe's going to work 5% on this grant and 10% on that grant and 50% on this grant. And before you know it, Joe is like 325% of an FTE. So there's no way, I mean, maybe he can, but there's no way, you know, maybe he can do it in reality, but his salary is not that large. So we'll see cost allocation or claiming processes based on estimates, which isn't allowed. You have to have actual statistics to back everything up. But oftentimes you'll see these grant applications and grant awards aren't reconciled with cost allocation practices. So it's that, you know, issue of Joe suddenly being Superman, and it's also, you know, just the fact that sometimes I'll see folks that are funded with grants they actually don't work on. So some funders care about that. They should care about that. So a cost allocation plan can also help you kind of get all of that straight and can give you better data for when you go out and do your, you know, $10,000 grant awards and so forth. So with that, we've got just some conclusions about the cost allocation model, and I'm going to open up for questions. Someone has to give me at least one.
I have a question.
Yep.
Dolores Cooper from New Hampshire.
Hello.
Hi. On the allocations, we have most of our allocations are people-based, or people are doing full-time keeping. And there are some instances where at the end of the month, our cost allocation is run monthly.
Yep.
So if somebody's doing full-time keeping, you know, they have to fill out their little timesheet and send it into cost allocation to be tabulated and used for the plan for that, for the, you know, if we're doing April cost allocation to get that last week of April in. There's been some instances where people are not as good as getting their results, their time study into cost allocation at the end of the month. So it gets to a point where we have to say, we got to move forward with cost allocation. So we will use either the prior week's timekeeping or the prior month's timekeeping in order to calculate the month's allocation. Is that something that we should do?
You can do it if you go back and reconcile. Otherwise, no.
Okay.
So it's an interesting question. Are you doing it monthly and then consolidating all your quarterly results to actually do your claiming?
Yes, we do cost allocation monthly, and then what they do is they just take the results and give us quarterly reports for people that need quarterly reports. But I mean, most of our reporting is annualized, so when I go to pull the cost together, I pull the 12 months. Or if it falls nice and neatly on the state fiscal year, I can pull one report. But in the instance where, you know, sometimes people are, for whatever reason, they don't get their results in for a month and they're holding up cost allocation, there are at times when we've said, okay, use last month's results. And that was where you said you cannot estimate. Basically, that would be an estimation because we used not the actuals from, say, April to do the April results.
Right. Yeah, you have to use actuals, so unless you have a process to reconcile that, you're going to be in trouble. And where I would worry about it too most is I'm assuming the folks are direct time reporting because they work on multiple grants.
Right.
You're oftentimes, Vermont does it the same way, and it's a good practice because they have so many grants.
Yep.
And the thing is, you are going to have teeny grants, so you're going to have seasonality. So it's entirely possible too. It may come out in the wash depending on the grants, but it very well may not.
Okay.
Particularly with those small ones, and it's outside the practice. So you're going to have to either get them in. The other thing that you say that concerns me is that folks should, if you're doing positive, who here is actually, just asking the room, who does positive time reporting? Fair amount of you. They're supposed to be doing it every day.
Right.
I mean, every hour, really.
Right.
And so if you're not getting all your results into the end of the month, I would be surprised if that person is actually doing it at a frequency to which you could document its accuracy. Let's put it that way.
Exactly, and I mean we try to stress that because, I mean, I see no reason why within 1 or 2 days they shouldn't have that signed by the supervisor and submitted.
Right.
But we've had some cases where, for whatever reason, it's not done, and that's something that we're working on to kind of get people to realize how important it is to get their results submitted.
Yep, that's important. For any kind of time tracking, time study, it has to be done regularly, continuously, ongoing, within the right time frame.
Great, thank you.
You're welcome.
Hi. As I mentioned this morning, in Oregon, public health is funded with 70 categories of grants, and we've been running into some problems lately where with some of the various federal agencies, they don't, in dealing with the federal agencies, that they're not accepting, they want an indirect rate as part of the grant application, and when we try and take the cost allocation cost and convert it to a rate, they then ask to see our cost allocation plan, and so I dutifully send the plan to which the project officer responds, there is no rate. There is no rate. You are now capped at 10%.
Do you have a report that shows the calculation? So when you send them the plan, do you send them the narrative, or do you send them financial reports?
We send the narrative.
Okay. One thing you might want to consider is there hopefully, every cost allocation plan ideally can show, okay, we spent $1 billion, and now we've re-engineered, reallocated, reshuffled our $1 billion. So this is what we spent on, salary, light, people, and then this is what that $1 billion benefited. And hopefully what you can show is for every single grant and program, you can show here's how much of the light, heat, people, et cetera, went there. If there would be a way that you could take that and express that math as a rate, I would hope that that would be, and that's what some other states I know of have done to try to get around that. Because I don't know that they know what they're asking for, but I'm imagining someone that's asking for an indirect cost rate, and indirect cost rate proposals don't have the narrative. They're very math-oriented. They have no explanation, really, of things. It's very high level. So probably someone that's used to seeing that, if you're sending them a narrative, it's going to confuse them. Thanks. Does that help? Yeah.
This is Abby from Minnesota. We're one of the departments that has kind of the plainest vanilla indirect rate, and we're recognizing that as we've gotten larger and more complex, that's not probably our long-term solution. But a couple of things we've thought about is, one, while it does create winners and losers, it creates a lot of stability on the budget side for programs. So they always kind of know we have that one rate, and it's that rate, and they got to plan for it. So I'm curious, if you were to move to a cost allocation plan, how much variability in the cost that introduces on the program side. And then on the other side, we have kind of complete fungibility on the indirect costs. So we put that all into a pot, and we can shift quickly between, you know, if we've got more IT priorities this year or more facilities priorities the next year, that money is all fungible on the sort of indirect spending side. And so are there restrictions in how you, does that reduce the fungibility when you're spending the money you claim? Does that make sense?
Yes, a few things. I think going from an indirect cost rate to a cost allocation plan will cause some pain somewhere. It's hard to know where. So I think that happens. But one of the things about an indirect cost rate is that it's done in arrears, and usually it's 2 years behind. So the problem is, at some point it's going to catch up with you. If there's a big reorganization, if there's a big capital purchase or something else, I've seen it cause a lot of problems down the road because all of a sudden it's like, well, we've been used to 10, 10, 10, and now it's 15 or it's 12 or it's whatever. So I think a cost allocation plan over time is more predictable. It's and so forth. In terms of the sort of, I think the biggest thing you just got to be making sure is you need to apply that indirect rate or your cost allocation plan to every program, and just make sure that whatever you're doing, you're not using some grants to defray the cost of others. And that's the piece that, no matter what methodology you're using, concerns me the most. Because I've seen agencies take a statistic and allocate their indirect costs and not include 20 grants because they say, well, those grants won't allow us to allocate there. So that's the piece I would be most worried about.
Can I ask a follow-up unless someone has a microphone?
We have one other one. Go ahead, ask a follow-up.
One of the things we were also looking at is whether we just need multiple indirect rates instead of a cost allocation plan. If it's a quick answer, is there sort of pro and con on that approach from your perspective?
I think by the time you get into multiple rates, you might as well do a cost allocation plan. Because essentially that's what you're doing. Yeah. Yep.
Hi, Sherry Watkins. I'm with Utah. We have the Medicaid agency within our health department, so we do a complicated cost allocation plan. We also do an indirect rate, which is an indirect rate for the centralized folks like me, finance office, HR, and our technology services. I have two questions actually. But for our indirect folks, in some instances, we also do where it's a specific project not readily assignable to all grants or doesn't benefit all grants, we do a direct charging. For example, if an auditor does a VSC vaccine audit or a WIC audit of charging the local health department, we direct charge those. So my question is, and normally these folks are in the indirect rate, have you had any experience with any difficulty in direct charging as long as you timesheet for those activities, and the rest of the time would roll into the indirect rate?
Shouldn't be a problem if you have the proper documentation, because it would be incorrect to include someone that's that dedicated in
a specific activity.
Right, in the indirect cost rate. And that's another big thing you got to be careful about. If you're doing an indirect cost rate, you got to be very careful about what's in that numerator, because it's only the people that you truly can say work all the way across. If you have an auditor, like in your example, and they're also contracting, but for whatever other reason, but they're in the indirect rate, you're kind of proving that you shouldn't have them in the indirect rate. But if you can truly say that this portion of their time is only on this and then the rest is general, you can treat the portions both ways. I'm going to just want to make sure that documentation and the time study that you're using to do that is up to speed on the reg.
Second comment on your indirect rate being negotiated and the 2-year.
Could be 2 years.
Or it's 2 years for your actual cost. We had a huge increase in our centralized technology services. It hit our agency over $1.5 million increase. And we went for a service from $800,000 to $2.3 million. So we have done a prospective analysis or estimated for our indirect rate. We haven't had that approved yet, so have you had any experience with that? It's still sitting in San Francisco at the DCA, the Division of Cost Allocation for approval. Have you seen them approve that prospective? We're going to have the increase, but the rates are determined on actual costs from a year or 2 years prior.
I have not. I mean, I would just really make sure that dialogue is open with them on that rate so that they know, because and try to prove, they want to say to them that this is going to help us from having to go back and readjust everything.
No, we're not speaking to them daily.
Oh, that's good.
Yeah. Maybe one last question. Hearing none. Bill, did you want to just say your...
Oh, okay. I was just going to say we did have an experience very similar to what you had or you're having in Utah. It was with the education agency at the federal level when we were at DARS, and we got that approved. So, again, the dialogue is real important.
Great, thanks. Anything else? Well, thanks so much, Amy. How long are you here for?
I'll be here this morning.
Oh, great.
Yeah.
Okay, good. Well, thanks.
Thank you. Please stand by.